This is going to be topic 52, multi-systems trauma, trauma resuscitation.
Key concepts. Upon completion of this chapter, you'll be able to understand shock versus hypoperfusion, goal-directed therapy and shock trauma, permissive hypotension, and then hemorrhage control. In the preceding chapters, we detailed the breadth of trauma care, and then what that means is we've hit all the areas of trauma care. Critically ill patients with multiple injuries, we prioritize their treatment. Prevents us from becoming too focused just on one problem. Critically injured patients require a holistic approach, and that's an overview approach because critically injured individuals have multi-system trauma. Chief concerns is going to be shock, which is inadequate oxygenation. One book that I had one time suggested that shock could be summed up in one word: hypoperfusion, so low perfusion, independent of blood pressure and etc. Overarching goal for this: enhance the delivery of oxygen to the tissue. So that should be our primary goal whenever we're looking at the treatment of shock. Now, if they don't have enough blood to perfuse, if they don't have enough oxygen, they don't have enough red blood cells to carry the oxygen, multiple problems arise in this. Hemorrhagic shock is the most common type of injury that we see. Oxygen delivery to the tissues. Key components: if there's any obstructive airway of any sort, please clear the airway. Many things can interfere with the airway: unresponsive patient, the tongue, losing control of the tongue and the fall into the back could occlude the airway. Adequate oxygenation, high flow, high concentration, supplemental oxygen, adequate ventilation, oxygen introduction, and carbon dioxide removal. Now, this is a process as far as adequate ventilation goes, that it's a process by diffusion that occurs in the alveolar sac. This is the vessel. So in the alveolar sac, there's a higher concentration of O2. We're coming back, there's a higher concentration of CO2, and it doesn't exchange because of diffusion. But both of these are important. Not only is it important to load the oxygen, but it is also just as important to offload the CO2. High amounts of CO2 or lots of building blocks will create a considerable amount of carbonic acid, which will adjust the patient's acid base. Adequate circulation is affected by blood loss. If we lose all of our formed elements, we have nothing to carry the oxygen with. Hemorrhagic shock, pathophysiology, acute blood loss. Hemorrhage, the body cannot rapidly stop. So whenever we look at acute blood loss, there's too much going out and there's not enough coming in. The body can compensate for a little bit of blood loss, but for the most part, if we lose a third or half of our circulating volume, that puts us in dire straits. Compensatory mechanism is to stimulate the sympathetic nervous system or fight or flight. Heart beats harder, faster, stronger. The vessels constrict down, shunting blood towards the core organs. The baroreceptors and chemoreceptors monitor this. Chemoreceptors look at pH, carbon dioxide. To a lesser extent, they look at oxygen. The baroreceptors are stretch receptors that look at how much pressure is in the system. If there's not enough pressure, the body will start sacrificing organs. There's a line of survivability, if you will. All the other organs will get sacrificed to maintain the brain. So heart, lungs, liver, kidneys, brain, essential organs. Decompensation, the body, whenever they go into decompensated shock, they cannot compensate for the demands that's put upon them. So the sympathetic nervous system initiated things, can't keep up with it, and then we continue to bleed, continue to bleed, continue to bleed more. The vessels shut their precapillary sphincter, they shrink down, the heart beats harder, faster, stronger for more output. Long story short, you can't maintain this. If you keep bleeding out, there's no supply. So fluid boluses are important, but as far as fluid boluses go, if we put enough fluid on board to make them bleed pink or get rid of all the formed elements, they still can't carry the oxygen. So blood loss, decreases the amount of preload that's coming into the pulmonary trunk, which reduces the stroke volume, which in turn reduces the cardiac output, which that reduces the blood pressure. Without this, organs don't get perfused. This is Frank Starling's mechanism, and what it essentially breaks down to, or the Barney version of this, is that if something is stretched to a certain point, it has a greater output. So the preload coming into the heart stretches it and gives it an ample supply of blood. Now, then due to the contraction and the size of the vessels, what we get is blood pressure and cardiac output. Initial patient contact. We should get an initial impression, sick or not sick. Global assessment on the contact. Several factors affect this. If any of these factors are seen, decreased level of consciousness, noisy respirations, pale gray mottled cyanotic skin, abnormal respiratory pattern, abnormal chest wall movement, uncontrolled external hemorrhage, and any combination with anything above, and that would consider they would get the global stamp of sick. Need to step it up. You're already behind the curve. So you probably have an ABC problem, so you need to get on the ABC problem as fast as you can. Clear the unobstructed airway. Key component is going to be oxygen delivery, non-rebreather mask, 15 liters per minute. Assessment begins with the initial encounter. What's their overall mental status? How's their respirations? Do they have any kind of face or neck trauma that might impede you placing an airway? Management plan. Compromised airway of any sort should be aggressively managed. You may have to bump up your IV or IO to initiate or facilitate an intubation. Glasgow Coma Scale, below 8, the patient should be intubated. Airway management techniques, adequately pre-oxygenate the patient first. Repeated attempts at intubation reduces the success rate. The book suggests a total number of 2 times before switching to an alternate means. An example of this would be a supraglottic airway. Adequate oxygenation. Oxygen to the tissues must travel into the bloodstream to get to the tissues. Assessment of hypoxemia signs. If they have an altered mental status of any sort, confusion, combativeness, cyanotic mucous membranes, lips and tongue, pallor, secondary to hypoxemia from circulatory collapse. So pallor also can be caused from a diaphoretic shunting of blood towards the core. Hypoxemia measurement, pulse oximetry on the forehead or pediatric lobe. If we place a pulse oximetry detection device on their finger and they shunt it towards the core, we may not be able to see the sample because of the decreased circulation. So put it on someplace central, earlobe, forehead. Pediatric detection devices might be helpful in this. Management plan. Critical injured trauma patients, high flow oxygen. Methods, non-rebreather mask, assist their ventilations with a BBM if necessary with oxygen reservoir. Endotracheal tube intubation to secure the airway, and then a backup device of some sort of supraglottic airway. All of these methods boost oxygen saturation to 100%, and if you are loading, supersaturating what you have available on hand, if you have been in hemorrhagic shock, then that will bridge time. The true treatment is blood, so you have to do this quite rapidly and very quickly and get the patient to the appropriate facility. There are few consequences with high flow oxygen in the trauma patient. Adequate ventilation, air movement in and out of the lungs. Oxygen diffuses, we talked about that just a second ago. If this is a semi-permeable membrane, this is the alveolar side and this is the venous side. Diffusion occurs because the oxygen concentration in the alveolar side is higher than the return sample that has a CO2 in it. The only thing that this is going to try to do is balance the amount of CO2 on both sides and also balance the amount of oxygen on both sides. Assessment of this chest, symmetrical rise and fall of the chest. Asymmetry may indicate the presence of rib fractures, a false chest segment, or pneumothorax. Auscultate their breath sounds, and this provides an anticipation of the equality of the breath sounds. So auscultation of breath sounds are important. They also give us one of our first clinical glimpses at a developing tension pneumothorax. Increased work of breathing. If the patient's using every muscle in his upper chest to try to breathe, then you should take note to that. And instability of the chest wall, broken mandible, below chest segments, multiple rib fractures, all of these would say instability of the chest wall. Patient not ventilating adequately, ensure respirations are assisted with a BVM device or prepare for definitive airway management, and that means intubation. On a tension pneumothorax, we correct it immediately just over the third rib. Mid-clavicular line is the best spot. At least a 5-centimeter needle should be utilized performing a needle thoracostomy. Open pneumothorax, occlusive dressing. There's aftermarket devices out now like the Halo dressing. Regular dressing with an open side, and this would be like 3 sides. So tape 3 sides so that it works like a flutter valve. Adequate circulation is challenging. Liberal fluid administration consequences, and the consequences are if we thin them completely out, they have no formed elements, they do not have the ability to carry oxygen to the tissues. Other shocks may be present as well. Don't get tunnel vision in. There's just one type of shock. There may be hemorrhagic shock present. If they've had spinal cord trauma, there may be neurogenic shock present. So keep your options open, if you will, and be sure that your clinical assessment of each one of these, the clinical assessment on them is clearly seen, and then that clinical indication formulates your field diagnosis. Assessment: poor perfusion indicators, skin color and capillary refill, the blood pressure, low diastolic pressure, and then uncontrolled hemorrhage. Even if they have a good blood pressure up front, if you can't put a patch on it or slow down the bleeding, it's not going to come out well. Management plan: hemorrhage control, control of bleeding, sufficient bandaging. We need that blood to soak into there and formulate a clot. Pressure, and then do not put a tourniquet on. And what I'm trying to say is if you can't get the bleeding stopped, don't be afraid to pull the trigger on a tourniquet. Get the tourniquet on there. The bleeding will kill them a whole lot faster. They can repair those vascular beds in surgery. So get the tourniquet on, stop the bleeding as fast as possible. Fluid resuscitation. From the decades of debate, we've kind of gravitated towards minimal fluid administration. What we don't want to do is we don't want to thin them out so much that they have no oxygen carrying capacity. Another thing in the formed elements is our clotting factors, our ability to initiate a clotting cascade. So the more that we thin them out, the less that they can clot. So it's kind of like a domino effect. Administration: small boluses of intravenous crystalloids, normal saline lactated ringers, until reaching one of the following endpoints. If you have a radial pulse, appropriate mentation in a non-head injury patient, mean arterial pressure 40 to 60 millimeters of mercury, or a systolic blood pressure of 80 to 90 millimeters of mercury. MAP greater than 60 in patients with suspected traumatic brain injury. They have to be able to perfuse their head. Cerebral perfusion equals intracranial pressure minus the MAP, mean arterial pressure. So as the intracranial pressure goes up, the mean arterial pressure has to go up to allow for cerebral perfusion to occur. Management plan: neurogenic shock, a form of distributive shock, and what distributive shock means is it is a vascular problem or a container problem. They respond poorly to intravenous fluids and may require vasopressor medications, norepinephrine and phenylephrine, because it is an alpha agonist or stimulates the alpha receptors, which would cause vascular constriction. The problem with neurogenic shock is there is no more stimulus from the neural end to the vascular bed, so the vessels become much larger. You don't have enough fluid in the system. Adrenal insufficiency also. Patients may carry medical alert bracelets or a card or an emergency steroid kit. These patients would not have enough adrenaline from the adrenal insufficiency to have a sympathetic nervous response. In conclusion, critically ill patients should be holistically cared for, an overall approach, clinical indication found, field impression, get ahead of it, aggressively treat the ABCs. Multi-system trauma care, patent airway, oxygenation, ventilation, and circulation are primary.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, Smith Art, Samaritan EMS, OK.com, or 405-492-8243. Thank you.